Shall get started. So going back to our talk of pediatrics, we'll start out with some neonatal intensive care stuff. These are for the very small babies. Sometimes we'll be seeing. Typically, depending on where you work, you might see some of these patients being either born in your institution, if they come into the ED or something. Very rarely do we have actual mothers or babies being born actually in the emergency department. Usually they're already head out at that point. But sometimes, if you're working in the Peds institution, you may see kids transferred in for this. If you work at Wendy Palmer, I'll say that the mothers and babies unit are already there, so kind of everything is kind of self-contained. So it really just depends. But you may have some of these kids presenting during that first 28 days of life, especially to EDs or urgent cares and things like that, who may have some of these issues. So we'll kind of go over some of that. So obviously we already mentioned kind of what time frame do we consider to be a preterm infant? Yeah, so less than 37 weeks. So a lot of these kids, obviously, the more premature they are, the less developed they are, the more likely they are to see some of these kind of complications, right? So we will kind of see that, there's many kind of very important stages of development. Obviously, kind of what's, for organogenesis, what's kind of the most important stage? Yeah, first trimester generally. So that's where a lot of drug effects can be playing a role here, but obviously other things can be affecting children. Maternal drug use being one of the big ones, at least from my standpoint. Obviously alcohol can affect them. You can see fetal alcohol syndrome. You can have, drug use such as cocaine and opioids and things like that. All can be affecting the baby. Even things like SSRIs that the moms might be on for depression. Babies can also have effects with that, right? Because what happens when you stop taking your SSRI, you have withdrawal effects. Same thing happens for the babies as well. So lots of different issues that can kind of pop up for these kids. So there's kind of different terms that we'll use for these kids based on kind of what their birth weight was, and they get very, very tiny, even less than 1,000 grams. And so obviously they're going to be kind of very at high risk for medication errors because the dosing you're using is so tiny for these guys. Usually the volumes we're administering can be on the 0.0 ml kind of scale here. So we're not talking about big volumes, and so they're very kind of at risk population in a lot of senses. But you can see here where kind of a lot of the different organs are really kind of developing and maturing, and obviously, the earlier born, the more underdeveloped they're going to be. So, especially if you look at things like, looking where the teeth develop, this is where things like tetracycline, use in the mother can obviously be affecting them, and so any kind of drug exposure can be affecting the child, throughout this time frame. But one of the first things we'll talk about is neonatal sepsis. This is a very common thing you may need to be treating patients for and ruling out. A lot of times you're going to be using kind of more 48-hour rule out kind of treatments for these patients. So anytime, especially within the first 2 months of life, fevers in a child can be very troubling, right? There should be some cause for alarm because you don't know, is it just a cold they got, or could it be actual meningitis or something like that. So you have to work them up, and you have to basically kind of go through and treat them kind of as a worst case scenario until you can kind of rule things out. So this is where you use a lot of 48 hours of antibiotics to try to rule that stuff out. But we will consider neonatal sepsis during the first 90 days of life, bacterial infection. So not super common, but is one thing you definitely want to be kind of on your game for, because obviously, especially in sepsis, the earlier we can get treatment started, the better outcomes are going to be, and this holds true here as well. You can see that the three kind of main types of neonatal sepsis that can occur either are occurring kind of in the intrauterine space during actual delivery itself, and then in the hospital they can kind of acquire it as well. And so why do you think this matters as far as kind of the three different types you might see? Yeah, the organism, right? So obviously the organism can change based on that, and then that's going to mean that the treatment's going to be changing based on that. So it's important to realize what type of antibacterial coverage you need to take for these kids, and make sure you're making the right choices on the meds you're going to give. So I mentioned kind of other risk factors these kids may have for neonatal sepsis. Obviously having fever during labor, or mom having a history of group B strep, things like that, all can be affecting their risk and increasing that for developing sepsis. I'm not going to go over this in super detail because I'm sure you get it in your Peds lectures. But this is important. So determining what your antibiotic therapy is going to be based on their time of presentation, right? So obviously the earlier the onset, so say within that first week, that's going to be making it more likely to be coming from the mom, right? It's going to be more of that kind of perinatal type of infection. So notice that the organisms change a little bit. So certainly, skin flora, Things like strep are obviously going to be of concern in either late or early onset sepsis. But you notice kind of what's the big change in bacteria for the early sepsis. Listeria. So Listeria is a big one you want to keep your eye on, at least for early treatment of sepsis, right? So it's going to be changing what type of drugs you're going to use for those patients. So again, mainly if the early onset, you may see more bacteremia being kind of the thing, just because they have such easy translocation of the bacteria. A little bit later on, it could be more of a focal infection potentially, or it could be bacteremia. It could be one or both, right? So looking at empiric therapy for early onset sepsis, if you guys will remember back to when we talked about antibiotics many moons ago, ampicillin has good coverage for Listeria. So anytime you're trying to cover, especially for meningitis or neonatal sepsis, ampicillin is really good for Listeria, and so you use that for the very kind of young patients. And who else is at risk for Listeria? Yeah, older patients as well. But here we're using ampicillin for the Listeria coverage especially. And then you actually add on gentamicin, which is what type of antibiotic? Aminoglycoside. And we already mentioned that kids, when they are this young, they have a lot of altered pharmacokinetics, right? They have a high water content for them. We know that gentamicin is a very highly, hydrophilic medication. They have poor kidney function potentially, or it's kind of starting to develop. So lots of things you get to watch out for. And so this is where you're looking at, okay, what was their gestational age? What's their weight currently? How are we going to be dosing this? And how frequently are we going to give it? So, here like gentamicin you may give every 24 hours, but for some of those more underdeveloped kids, you may be giving every 36 or 48. So make sure you're checking your dosing on that to make sure that, especially, if you're in the ER setting, like, you can just do a single dose and send them on their way, and then you don't have to think about it, right? But should you be following up the NICU or you're treating these kids on the floors, like this is going to be where you need to actually do those checks and make sure you're dosing them appropriately. For the most part, you will kind of work them up. You'll do usually 48 hours of treatment, and then if they are not growing anything on cultures, then potentially, and they're clinically improving, then you may not need a full 10 days. But if you do grow something out, then obviously you would pair back therapy based on what they're growing, and then treat for that full 10 days, right? What's it really important to do before you start the antibiotics? Blood cultures. Yeah, make sure you're doing your blood cultures. What else might you do for a kid who's coming in trying to work up for sepsis? This kind of age, for like meningitis. LP? Yeah, you might do like an LP as well, right? So you're doing LP, like you want to make sure you're doing that beforehand if it's feasible, right? So it's one of those things where you don't want to delay antibiotics, but obviously getting your cultures beforehand is super important, because if you give antibiotics and then you get your cultures, nothing grows, you can't say whether or not it was the antibiotics that affected that, and then you have to kind of go for the full treatment, okay? So keep that in mind. So other factors that kind of are predictive of death or other kind of serious sequelae for these kids, obviously if they are having things like seizures, or if they are obviously having any kind of blood dyscrasias and they're not really able to mount a good immune response, any of these things can lead to kind of worsened outcomes for these kids. So obviously the earlier the treatment, hopefully we can prevent some of these from occurring, and hopefully prevent kind of long-term complications for these kids from happening. With more late-onset sepsis, the treatment changes pretty significantly. So we're not quite as concerned with the risk for Listeria. So ampicillin can still be used because it'll still get some coverage, against like group B strep and things like that. But because you might be more worried about skin flora, you might be more worried about things like potentially like community-acquired MRSA, things like that. You can potentially even step up your treatment a little bit. So you can use something like ampicillin or vancomycin. Vancomycin going to be good for what type of bugs? Yeah, your MRSAs, your group B streps, your gram-positives, basically, right? It's not going to cover any of the gram-negatives. And then you have your gentamicin, or you can use cefotaxime, right? Cefotaxime, do you guys know what type of drug that is? Yeah, third generation cephalosporin, right? So we're not going to use like little wimpy cefazolin. We're going to be bumping up to a third generation. So like for a lot of my docs in the Peds ED, we would use ampicillin and cefotaxime. The brand name for that's clafrin. So if you ever hear like amp and claf, like that's usually what they're using for those kind of late onset sepsis patients, right? So that way you can go ahead and get so most frequently what I would see at Nemours is for patients who are being transferred from another hospital where the babies were born, they get transferred to us for NICU care. They would often get the ampicillin, gentamicin for that initial workup. We'll look at there's some other risk factors we may need to treat kind of empirically, but and then for the late onset kids who are showing up who are say like just a few weeks old, we would go with ampicillin and the cefotaxime. right? If I'm using a third generation cephalosporin, how come I can't use a drug like ceftriaxone? Can't use it in the first month. You guys know why?
It displaces bilirubin.
Displaces bilirubin, causes jaundice, so you don't want to do that. So we use cefotaxime instead. That's our go-to third generation cephalosporin for that first month of life. Okay, so it's a key point to remember there. For bacteremia, you can treat for 10 days. It's usually enough to eradicate most of those infections. But if you do have a true blue meningitis, you have to treat for longer. Why do you think that is?
It gets into the brain tissue. You gotta pour it out.
Yeah, it's a more protected site. It's harder to really penetrate that tissue in a lot of cases. So that's why we need to treat for longer to make sure you really try to eradicate that infection. Because anything you leave behind can start to grow again, and you can see recurrence of disease. So we don't want that to happen for these kids. So how do we try to prevent group B strep sepsis? So part of that's going to be reliant on testing the mother. And so you're going to see that most pregnant women should be screened between 35 and 37 weeks of gestation to see if they have any kind of colonization with this. And so if that is the case, and they end up getting intrapartum antibiotics, and they should be given if the group B strep is isolated from the urine of the mother, or if she's been identified as a carrier for it. Right, and then if the patient, say it was someone who didn't really have good follow-up, they never got tested, and they show up and they're in labor, then you will see they'll get the antibiotics if they have an unknown status and they have the risk factors of having gestation less than 37 weeks. If they're another premature, we know they're going to be more at risk for infection. They have a ruptured membrane for a prolonged period of time, so like greater than 18 hours, or if they already have a temperature. Okay, so all those things would lead you to say, okay, let's go ahead and give her antibiotics. The risk is high enough that I want to go ahead and try to prevent this from happening to the baby. So what do we give? We give penicillin basically, and so here we just use basic penicillin G. Basically, you just give like a big loading dose, and we know that penicillin G is time dependent or concentration dependent. Time dependent, right? Because remember, that's why we give it very frequently, because it's a relatively short half-life and it's time dependent, and you want to keep that level above the MIC as long as you can. So that's why we give penicillin G every 4 hours during the labor process to make sure that we keep levels high enough to eradicate any of those bugs and hopefully prevent transmission over to the baby. You use something like ampicillin instead, potentially, that will also have the same kind of treatment there. And if they have a penicillin allergy, then you have a couple options. So you can use something like cefazolin or other drugs that mainly cover gram-positive. So clindamycin's fine here, vancomycin's okay here, but usually you can get away with cefazolin being first generation cephalosporin, penicillin, any of those kind of more wimpy antibiotics would be fine in the situation. So trying to prevent this once you have the baby born, how do you manage that patient? So if they're kind of ill appearing, not looking real great, you can do kind of your full diagnostic evaluation. So obviously you do things like CBC with differential, you do your blood cultures, you get your lumbar puncture with culture as well. And in this case, if they're born, they don't really look good, and this is why a lot of those kids get transferred to us over at Nemours. If they're born at primarily an adult facility, this is where they get started with empiric treatment of AMP and Gen, right? So get started for that, and then primarily, if they start to improve and they look good, then they'll go ahead and discontinue that within 48 hours or so. So call it the 48-hour rule out for a lot of these kids. So most of them don't continue on with it, but just depending, if they're high risk, they go ahead and do that, because the risk of infection is, or the potential problems with infection are much higher than any antibiotic side effects. So just kind of a little thing that can give you a good idea of, if you have a healthy appearing infant, what are the risk factors and when should you be treating with empiric antibiotics. You can see here where, say they are, let me get my laser pointer. So if they are, gestation greater than 35 weeks, so not real premature, you would say, okay, well, how soon did the mother get the intrapartum antibiotics in relation to when the baby was born, right? So if they had it for a good long period of time, so say greater than 4 hours, then you may not need to do empiric antibiotics. You can basically just do your workup, do your labs, and then just kind of observe, right? If they had less than 4 hours prior to delivery and we don't know the mom's status, or she did have group B strep beforehand, then in this case you would want to go ahead and just do empiric antibiotics. Okay. So this is for the more premature kids. Do empiric antibiotics if the mom didn't have good coverage for antibiotics beforehand. Whereas if they were older, if they were greater than 35 weeks, then for the most part you can just observe for 48 hours. Especially if the mom had the antibiotics on board for a decent amount of time, you really don't even have to do all the cultures and whatnot, right? So this is for the more healthy appearing kids, right? If they look pretty puny when they come out, probably better just to do your full workup and do the 48-hour rule out. Okay. Another thing you have to be really worried about, especially in the neonates, because they have kind of a poor immune system, is neonatal herpes. So can be caused by HS1 or HS2. Usually HS2 is kind of the more common one. What do you think that is? It's in the area, right? So, of course, the baby might be more likely to be exposed to HS2, but certainly HS1 can establish an infection down there as well. So that's kind of why that makes sense. Obviously, it's being transmitted to the baby through the genital tract, and so you can see lots of different issues with kids that pop up. Certainly, skin lesions can be a pretty obvious one, but you can kind of have other things that may not be quite so obvious. So, like for instance, if you had this kid that looked pretty puny, you give them antibiotics, but they're really not getting any better. They have really kind of bad temperature instability. They develop seizures, having apnea. This could all lead you to think, okay, there's something else going on. I didn't culture anything out, even though I did antibiotic. Did cultures appropriately before the antibiotic. What's going on here? Obviously, cultures do not test for viruses, right? So that's one of those things where you may have to actually do a separate test to see if they do have a virus, and you may treat empirically with something before you have those results back. Did you guys think of what drug we might use for this? Acyclovir is going to be our go-to drug for neonatal disease. So certainly you can have localized infection. This may only have kind of skin lesions, may have mouth involvement, eye involvement, but basically there's no CNS penetration, right? Because really the herpes encephalitis, like that's really the herpes meningitis. That's the big thing we want to prevent because that can be really devastating to a lot of these kids. More disseminated disease is going to have more organ involvement. This is where you can have encephalitis. So you can see with some CSF changes. If the kid's having seizures, like chances are they're having some CNS involvement here. So that's usually kind of a bad sign for a lot of those kids. But the indications we would treat for this, so if they have active lesions, then yeah, you want to go ahead and treat because they already are showing you kind of a skin manifestation that still means that the virus is around, puts them at risk for the more disseminated disease, or if they have any kind of any inclination that might be there, you can go ahead and initiate treatment. Acyclovir is our go-to drug of choice here, and so basically you can do it for 14 days. For more localized infections, but again, when you see something like meningitis, like this is when you need to treat for longer, so 21 days for a lot of those kids.
So are they hospitalized the whole 14 days then?
Yeah, usually. Yeah, because this is IV treatment, right? Because you want to make sure you're getting the drug into that patient and getting them very well treated.
Are they otherwise healthy?
It depends, so sometimes they'll have a bacterial superinfection on top of that. Sometimes this could be their only issue they have here. So again, like, it's one of those things where, what I see normally is like a kid coming in, being transferred to us, to our NICU. They were looking pretty puny. They were premature. They go ahead and get started on 48 hours of antibiotics, but they're not really improving. And at that point, once you have an inclination, there could be herpes involved. Obviously, you're testing for it as well. Or if the mom had it beforehand, obviously that would increase your risk. But some of these kids, when they come in really premature, they have drug exposure. Like mom probably wasn't getting a ton of good prenatal care anyway. So those are the high risk patients, right? In those cases, you may just go ahead and treat and see if they start to improve. Obviously, if they're getting better, then that kind of gives you a good sign, and especially if you're testing for HSV as well. But yeah, so that could be the only problem they have. There could be lots of other things, right? So they could be having issues with apnea. They may not be feeding super well, so you may be having to give them supplemental feeds. A lot of these kids end up on TPNs, which is total parenteral nutrition, where basically we have to give them all their nutrition through an IV, electrolyte disturbances, all kinds of other issues that can pop up secondary to this kind of viral infection, right? So these kids can be sick for a number of reasons other than just the infection. Other things that you can see when you have premature babies being born is respiratory distress syndrome, or it's RDS. Basically, when these kids are born early, they're going to have kind of an immature lung anatomy and some physiology. And so basically they're missing, and they've not really started producing a ton of pulmonary surfactant. And so what is surfactant really used for within the lungs?
Decreases surface tension.
Decreases surface tension.
Keeps them open, not sticky.
Exactly. So it kind of helps keep the lungs kind of attached to the chest cavity and make sure that nothing starts to collapse down, right? Because once things start to collapse down, we can't really oxygenate very well. So we can give actual exogenous surfactant to help kind of replace that. So Again, you're going to see atelectasis, you're going to see poor, this kind of VQ mismatch that's happening between the ventilation and the oxygenation for the patient, and can lead to permanent lung injury if we don't treat this early. So we have, let's say at Nemours, we have a transport team that will very frequently go out and transport these kind of very premature, very sick neonates over to us. And so this is one of the big things they worry about. And so this is one of the drugs they'll actually carry with them in order to help treat this RDS. Okay. So usually see surfactant production begin around 32 weeks gestational age, and then kind of matures around the 36-week mark, right? So if you have a kid who's like 37 weeks born, they're nice and mature, like you don't really have to worry about this too much. But when you get like the 28-weekers, the 24-weekers, like the really small ones, like this is when you're going to really worry about the RDS, okay? Other factors that can lead to increased surfactant production is if the mother was receiving steroids before birth. So again, something like dexamethasone or betamethasone, this could actually increase surfactant production. If you have prolonged rupture of the membranes, that can actually help to increase that as well. And then maternal hypertension, for whatever reason, seems to increase surfactant production, right? So if mom happened to be hypertensive beforehand, that may actually be useful for the baby. But the big risk factor is going to be prematurity. So again, most commonly in the low birth weight kids, less than 1,200 grams, less than 30 weeks gestationally. Those are your prime customers for that. For whatever reason, male babies tend to be a little bit more prone to this than females. And then lots of other things, so like rapid labor, multiple pregnancy, hypoxia. My sister, she actually had her first child at 33 weeks, so she ended up spending some time in the NICU. Is doing fine now, but now she's actually pregnant with twins and is due in April, right? So obviously twins are also at risk for premature labor, right? So she's been on progesterone this whole time, and so this is actually one of the big concerns is like, okay, well, she's due in the middle of April, like, we're hoping to get to the end of March, but this is one of those concerns where you worry about, okay, what kind of other side effects are they going to be having from this potential premature birth? We know that twins are going to be more likely to have this as well, so again, you start to kind of think about what are they at risk for, how can we kind of head off some of this if possible. But yeah, so these are kind of the big risk factors. These are the things that make you think, okay, they're at risk for having RDS. So how do we do this? We end up using a lot of prophylaxis for some of these kids that are less than 30 weeks gestational age, which means we're going to be, when they are birthed, they're going to be given surfactant. And I'll talk about how you administer that because this has a kind of a unique method of administration. If they get treatment, the prognosis is usually pretty good. They you can supplement that surfactant until they start to produce their own. And a lot of times we can give them, in addition, adequate ventilatory support. Usually within 4 or 5 days, even if you only gave them ventilatory support by themselves, they would kind of improve on their own. But again, you may have to, giving the surfactant usually just kind of helps and speed the whole process along. Also helps to decrease some risk for some other pulmonary complications like pneumothorax and other issues you can end up seeing there. The BPD or the bronchopulmonary dysplasia, you can decrease risk for that. So surfactant is going to be a good thing for these really premature kids. So there's a couple different varieties that are out there. There's Surfanta, otherwise known as Braractin, Curasurf. So you'll find that different institutions will have different drugs on formulary. That's just what they use. Notice here, though, that the method of administration, how are we giving this drug? The ET tube, yeah. You're an RT, so you kind of know. Yeah, so we give it through the ET tube. So ideally, it's not a drug you can give IV or give PO. It needs to go straight to the lungs, right, where it's going to have its mechanism of action. So you've given surfactant before. How do you administer it?
You intubate them just for the surfactant.
Mm-hmm. Yep, so you intubate them, and then how do you what do you do with them after you give it, right? In the position. Oh. Do you do any positional stuff with it?
No, not really. Just
okay.
Bag it in.
Well, some of our guys will actually do different positions with them, so that way you can make sure that the surfactant gets to the different areas of the lung. So they'll actually kind of reposition the kid prior to giving portions of the dose. So I don't know how common that is, but this is one of the things that some of our guys will talk about doing. But yeah, so anyway, these kids are intubated. You're giving it strictly to the ET tube. Sometimes you'll get multiple doses of that, so you can see it being given for every 6 hours or so. For like total of 4 doses. So really just depends the dosing, and again, notice the dosing is not in milligrams or micrograms, it's in mLs, right? So you're just dosing in strictly volume-based doses there. So mentioned, kind of divide it up into a couple different aliquots, or just kind of portions of the dose you're giving there, and you kind of give it 30 to 60 seconds apart, kind of moving them around to help try to get different parts of the lung there. And you'll see that like different brands will have different recommendations on ventilatory settings. I'm obviously no expert on that, but you'll just kind of have to follow what the kind of the protocols are for your institution there. Because these are proteins, you want to make sure that along with any other protein products, you don't want to filter it or shake the surfactant, because anytime you have a protein-based product and you shake it up, do you guys know what happens to it? Well, it gets foamy is what happens. So you see a lot of foam starting to develop. That's all the proteins starting to kind of come out of solution, and they get denatured. So any protein-based products, you do not want to be shaking excessively. This one is similar, right? So don't shake up your insulins, don't shake up your monoclonal antibodies, any of that kind of stuff, because any kind of foaming you see, it's a drug that's not going to be effective anymore for the most part. Okay. If kids have apnea of prematurity, this is another issue that can happen. So if they have like kind of respiratory pauses that are happening for greater than 20 seconds. I can tell you as a brand new dad, even though my child was born like 39 weeks or something, every time I was looking at her, I'd be like, is she breathing? Is she breathing? Is she going apnea? Okay, she's still breathing. Okay. That's about terror moment every 5 minutes, it felt like. But anywho, so normally what you end up seeing is that there's kind of two main controls for this kind of pulmonary ventilation for these kids. There's kind of a neurologic component where the cortex and the brainstem kind of help to regulate the rate and the rhythm of the breathing, and there's also the kind of the chemical sensor as well, where basically we're looking at things like changes in the PaCO2. So obviously if you increase levels of CO2, that stimulates you to breathe more. If they're low, that stimulates you to breathe less. And so you can see in some of these preterm infants that their kind of responsiveness to CO2 is diminished. Okay, so this is what, even though their CO2 levels are building up, they're not really triggering the brain to cause them to breathe, and that's where you can see the apnea develop there. So a couple different varieties. Obviously not all of it is strictly chemical. Some of it can be obstructional as well, especially if they have any kind of kind of mechanical problems or any kind of manifestations that are preventing the breathing. But the ones that we can actually treat with medications is going to be more with kind of the central apnea, or kind of a mixed component as well, right? So any kind of obstruction, obviously we can't really do much of that, anything with that with strictly drugs, but for the central component, we can treat that. Do you guys know what drug we give? A lot of you guys are on it right now.
Caffeine.
Caffeine, yeah. So we actually give caffeine. Yep. We'll talk about that in a second. But other causes of apnea in neonates, especially if you have any kind of like sepsis or intracranial hemorrhage, anything really affecting, really anything that's really knocking these kids for a loop. Hypoglycemia can affect this, hypocalcemia. Even though I spelled that wrong, I think I'm a British person apparently. Many lots of different factors that can lead to increased risk for apnea in these kids. So. Other things we can do to try to help prevent apnea, we can do things like avoid sudden changes in temperature. As you mentioned, they're kind of poor at regulating their temperature in a lot of cases, so that's why you put them under kind of the heat lamp, so to speak. Try to make sure they have good nasal patency, so they don't have any obstructive issue. And then for some kids, we'll give CPAP, so that continuous positive airway pressure. Hopefully we can avoid that if you can. And then even things like kind of gentle stimulation, so kind of tapping them on the foot can kind of help to trigger their breathing. Different things like that. But we'll of course focus on the drugs because that's what you're here for. So we give caffeine. Caffeine has the ability to help stimulate the respiratory drive. Do you guys know what drug is related to this we use for asthma? Yeah, theophylline, right? So these are methylxanthines, so they kind of fit into the same class and kind of similar activity. But you can give theophylline, you can give caffeine either a PO, you can do it IV for kids who are having maybe some issues with their GI tract. Give that as a loading dose, and then you can kind of continue that out as a maintenance dose daily from there on. So we like our babies well caffeinated so they're breathing well. And the nice thing here is that they don't metabolize it super well because their hepatic enzymes, as we mentioned, are not well developed. So it actually leads to a pretty long half-life. So this is why we can give daily dosing, whereas you guys are probably dosing up on caffeine probably every 15 minutes, right? So kind of using the kinetics and their immaturity to our advantage. Okay, so any questions on the babies? Yes?
Why does co-bedding help them breathe? And do we do that in the NICU? We like put them in the same little
right next to each other. I don't know the mechanism for why that helps. A neonatologist would certainly probably have a better answer for you. It's just one of the things that seems to help kind of that stimulation. Maybe if like one of them stops breathing, the other one can kind of nudge them a little bit, and who knows. Okay, so moving on, we'll talk a little bit about cystic fibrosis. You guys covered this previously? In Paul maybe, or in Peds? You see this a lot in pediatric patients. Fortunately, our treatment's getting better, so you see kind of older patients. Before they used to succumb to this fairly early in life due to a lot of complications of CF, but nowadays you're seeing older patients. But it's not uncommon that we still have patients that are like 21 and up that we're still treating over at Nemours, just because all their pulmonologists are, the CF experts are generally pediatricians for the most part. But anywho, this is obviously it's a genetic condition, affects primarily Caucasian patients. We see that, looking at Americans, 4 to 5% have at least one of these cystic fibrosis alleles. So this is it's one of those things where it's definitely, one of you guys may actually be carrying this around and not really know it, because it is need to have 2 copies in order to make that appear. We see that about 1 in 2,000 live births for Caucasians get affected by this. So it's probably a little bit more common than you might think. But again, as I mentioned, it's autosomal recessive, so you have to have mom and dad have this together. So again, it's like one of those things where it's like, you have a whole family of CF kids. I'm just like, you guys knew this is a possibility, right? Because, genetics, but they just want to have kids. So sometimes you run into that problem where you can see you have, lots of brothers and sisters that both have CF. So the cause for the CF is we have this mutation in the CFTR transporter. This will be important because we'll talk about one of the drugs that can actually help affect this, one of the newer agents we have for this. But essentially, and this is why you get salty babies, is because they can't really regulate a lot of chloride flow through these channels, and that's going to be really important for all kinds of secretory organs, as we'll see in just a little bit. Lots of different mutations, but probably the biggest one you're going to run into is this delta F508. It's the most common one. You see in about 70% of the alleles here in the U.S. have this mutation. So the CFTR channel, it resides on the apical side of a lot of epithelial cells, so you can see this in the airways, you can see this in the biliary tract, the intestines, even like organs like the vas deferens, sweat ducts, all of the kind of different places. Anywhere you have like kind of a secretory organ, usually have these CFTR channels here. And so basically when you have this channel being affected by usually that delta F508 mutation, you end up seeing the chloride cannot be sent through appropriately, right? So it's kind of chloride's blocked from going through there, and that means that fluid secretion is insufficient, right? Because wherever salt goes, water likes to go as well. If you're blocking that chloride, the water is not going to go that direction. So this means that secretions that have a high protein content are going to become very viscous, right? Because they're going to get dehydrated, so they get kind of thick, and they can kind of gum up the work, so to speak. So they can have a lot of blockages of a lot of these secretory type organs. So you can see this plugging, dysfunction, and as you might imagine, if you're plugging up your pancreas, if you're plugging up the lungs, if you're plugging up the biliary tract, lots of problems associated with this. And so there's lots of different drugs we can use to help kind of replace this function and help these kids kind of restore back a normal function for them in all of these organs. So again, we see the hallmark of the cellular defect here is this abnormality in the epithelial cell electrolyte permeability, which means that you're going to have less sodium and chloride permeability there. And so, like, what's one of the ways you can kind of test for CF? Yeah, do the sweat test. What is that? You lick them and then see if they're salty, and that tells you.
Wrap them up in a burrito.
Wrap them up in a burrito. Yep. Yeah. So you can do the interferesis to see if they're actually able to transmit salt appropriately. Yeah. You actually in pilocarpines. And what does pilocarpine do?
Pilocarpine stimulates the sweating.
How does it do that? Stimulates muscarinic receptors, and so you can end up seeing, because muscarinic receptor activation ends up leading to secretion of fluids and things like that. So again, if you give them pilocarpine and nothing really happens, then that kind of gives you a good idea that they potentially have CF. So lots of obviously we do genetic tests as well, so hopefully you can screen for a lot of this hopefully before birth, so you can kind of prepare. But again, this is kind of the hallmark there, right? So as I mentioned, like, sweat glands, they normally reabsorb sodium. They'll resorb that sodium at a normal rate, but the chloride kind of gets stuck out on the outside of the skin. So that's why we can do like the interferesis. We can do different tests in order to see if they have, but they kind of get that salty skin basically, is what they end up developing there. But you can also see really thick desiccated respiratory secretions, and you're going to see that the majority of the problems they run into is all respiratory, right? So when these kids come in for an exacerbation, it's all going to be respiratory based. They have really nasty, thick, purulent secretions in the lungs that make it very difficult to treat with antibiotics. So we'll talk at length about that in just a bit. So again, lung disease is going to be about 95% of the morbidity and mortality in CF, as I just alluded to, and we see lung destruction occurring via a couple of different mechanisms. One of it can just be due to obstruction with these really dehydrated, kind of thickened secretions. Like, you should see some of the stuff these kids spit out. It's kind of pretty gross for the most part. But they're going to have this resultant kind of endobronchial infection. They're going to have chronic infections here, and you see more of an exaggerated inflammatory response, because if they always have an infection around, there's always bacteria growing in their lungs, you're always going to have an inflammatory response there, right? So we're going to look at one specific antibiotic that we can use to actually kind of help mitigate some of that inflammatory action. So you're going to see bronchiectasis develop. You're going to see progressive obstructive airway diseases as a result of this. Okay, so infection is going to be one of the biggest things we're fighting in these kids, especially when they get exacerbated and they come in and see us on the inpatient side. So, as I mentioned, they're going to have dehydrated, tenacious, respiratory secretions. They'll try to find as many different adjectives to describe just how bad these secretions are, right? They're not really going to have good mucociliary transport, so they can't really clear a lot of that stuff, and it's going to obstruct in the airway. So, obviously, they're going to have poor oxygenation when they have some of these exacerbations, and you're going to see a lot of colonization of bacteria, especially a lot of really nasty gram-negative bacteria, as we'll talk about in just a little bit. So, things like Pseudomonas is going to be one of the big problems that we run into with these kids. But also you can have air trapping, bronchiectasis, atelectasis can all develop here as well. So we can see abnormal lung function, inflammatory response, and that's going to promote even further microbial growth. So basically you just have these really thick secretions that the bacteria can just kind of hang out in, and our antibiotics can't really get to it just because it is so thick and difficult to penetrate. Imagine kind of looking at a comparison of kind of normal healthy lungs on the left versus lungs that kind of get blocked up by a lot of that mucus and whatnot on the right side, right? So you can imagine how that just is a breeding ground for a lot of really nasty bugs. So, just an example of what the glands look like between a normal patient versus one who has CF. You can see how that mucus plug gets in there and kind of blocks things up, and that affects lots of different organs. Like I mentioned, the pancreas, the intestines, the biliary tract, lots of things get affected by this. So, any kind of secretory organ is going to get plugged up by these mucus plugs. So, with these early pulmonary changes, you're going to see a lot of dilation, hypertrophy of the bronchial glands. And so you're seeing a lot of inflammation, even if it's not related back to strictly just a bacterial infection. But even after like 6 months or so, you can see lots of these chronic and recurrent infectious bronchitis start to happen, and this is going to be repeated throughout the rest of their life. Like they're always going to be coming back in. They oftentimes will come in for these kind of tune-ups, as we call them, where they get they get a course of IV antibiotics, kind of get tuned up from that standpoint, and then get kind of back on a normal regimen. So it's a very common reason for admission to the hospital. They also have lots of high circulating concentration of antibodies just due to this chronic infection they're dealing with. So even though they're not really strictly immunocompromised from the sake that they have a normal functioning immune system, it's just they have this reservoir for bugs that they're never going to really get rid of based on their physiology. So big thing we worry about is going to be this colonization process with the bacteria. So you see lots of typical organisms, like you might imagine for some of these lower respiratory tract infections. So you can see things like Staph aureus, H. flu. The big thing you worry about those is going to be Pseudomonas aeruginosa. So those are kind of early on that you're going to see a lot of those infections that you're going to be treating for, but then even late emerging organisms, and usually when you see some of these bugs pop up, it's usually a sign that, okay, things are not really going in the right direction. This patient's getting worse, right? So this is where you see like Burkholdia cepacia, Synotrophomonas multifilia, things that me and you we can be exposed to, and we can clear those infections very easily. These patients, they end up getting, they get a foothold, and they can sit there and just kind of grow these bugs kind of chronically. So these are never good things. Obviously, fungal infections can be a risk as well. So Aspergillus can end up growing there. So whenever you see these bugs, that's usually not a great sign for your CF patient. The big thing with Pseudomonas is you have kind of two main phenotypes for this one. You have non-mucoid and mucoid. Do you guys know what mucoid means? Snotty. Basically it's like Pseudomonas just kind of covering itself with like this nice kind of thick layer of snotty armor, so to speak, and it makes it very difficult for these patients to get the Pseudomonas to get penetrated with antibiotics, right? So basically it has this alginate that kind of forms around. You guys remember back in GI when we talked about sodium alginate? What did that drug do? Kind of coated the stomach, made like a nice kind of protective barrier. The Pseudomonas is kind of doing the same thing here, which makes it very hard for host defenses to really deal with it. It makes it very difficult for the antibiotics to penetrate through it. So once patients kind of make that change over from non-mucoid to mucoid, that's also not a great sign, because that means that those infections are going to be much harder to treat. Okay, and that's one of those things that will be on, typically you'll do like a CF respiratory panel, and that's one of the things we're looking for, is to see whether or not patients have kind of transitioned over to that mucoid Pseudomonas. This is also why it's super important that when you're treating these patients to make sure to look at their previous medical records to see what they've already received, what have they grown previously, because that's going to be predicting what they're growing now, right? Because they never clear a lot of these infections, they're colonized chronically, so you're probably going to need very similar treatment to what they had before. So again, I mentioned these acute kind of chest infections or exacerbations that occur. This is oftentimes what they end up getting admitted for, is just they come up with a new, new pulmonary infection or new kind of exacerbation of it, so they're coming in for us. So they get these 2 or 3 week tune-ups, and again, they are going to be on antibiotics for much longer courses for pneumonias than what you would see for other patients. So again, they can be on 2 or 3 weeks of IV antibiotics, no problem, right? It's very, very common for them to do that. And then obviously, kind of what does that also put you at risk for? Constant antibiotics. C. diff can be a big thing. Resistance can also develop, right? So all these things are problematic when you're treating these patients for this long, right? There's some kids who are not really able to, they really just can't catch a break in some regards, and so they'll be back like every month or so, right? And they'll be in the hospital for, a month plus, So actually, one of our technicians, his daughter has CF, and so it's always really tough, because we always see her in there, just kind of coming back, and there's not a ton you can do about it, because even though you keep her as tuned up as you can at home, like there's always that risk there. Something's just going to knock them for a loop, especially in wintertime, especially when you have respiratory viruses can kind of kick off and kind of lead to an exacerbation that just kind of really throws them for a loop for the most part. But again, these, yes.
Do they go to school? Like, do you restrict their access to other children? And
Not that I'm aware of, but I mean, they go to school. They try to, because the goal is for them to lead as normal life as possible. Yeah. So you'll see that some of them will be on kind of prophylactic antibiotics. We'll talk about some of those a little bit later. But things that are trying to meant to try to prevent those infections. Obviously, you try to immunize them as best you can. Actually, I saw a car on the way here today that had all across the back window. It said the biggest lie we're ever told is that vaccines are safe and effective. I was like, I had a website, so I need to go check that out and see if there's any good information there. But anywho, yeah, so you keep them vaccinated, you try to prevent infection as best you can, but yeah, also like they're kids, like they want to lead a normal life, especially like teenagers and stuff like that. Like having a chronic disease as an adult, like kind of sucks, especially if it's like diabetes or something where like you kind of did it yourself, versus like a kid, like they really had bad genetics, like. Sorry for your luck, kid, but they deserve to lead kind of a normal life as much as possible, and so we try to give that for them. But you spend 2 or 3 months in the hospital, like that's kind of tough to do. Like you miss a lot of school, and yeah, a lot of issues with that. So again, talk to a social worker. They might they kind of works with a lot of those kids. They probably have a lot better perspective than I do, just handing out drugs, right? I don't just hand out drugs. I make recommendations too. I know what you guys think. No. Okay, so other complications of CF that we can run into. So gastrointestinal is also going to be a huge issue for these patients. You're going to find that a lot of them have this this meconium ileus, again, because their GI tracts can't really have a lot of good secretions, so they're going to have that be stopped up as well. So that can be one of those big signs. So that used to be one of the things we looked for before we had good, reliable genetic testing. That was relatively cheap. We actually, if they have meconium ileus, that was kind of one of those things where like, we should probably check you out for CF, right? Nowadays, you can usually check for that beforehand, because Florida, we do a lot of genetic testing, especially at birth. But you can see abdominal distension, MSS, lots of other things that can appear within the first couple days of life that could be indicative of having a kind of the secretory problem. But you're also going to be seeing kind of distal intestinal obstruction syndromes, other equivalents that can occur in older patients as well. So this can be very problematic for them from a GI standpoint. So you can see lots of acid and bile reflux. You can see esophagitis associated with that. They're also going to have issues with basically breaking down food and being able to absorb it appropriately. Because again, we mentioned with the pancreas being affected, what does the pancreas normally secrete to help digest food? Lipase, amylase, protease, right? So that's going to be one of the big things that they're not able to really secrete in a good enough amount on their own. We have to supplement that, right? So you can see malnourishment if they're not really getting good supplementation with those enzymes. You can see that a lot of fat-soluble vitamins like A, D, E, and K, ADEC, right? Those are going to be in poor absorption because they can't really break it down or emulsify those fats in order to absorb them very well, okay? So you can start to see how this med list is starting to get longer and longer for these patients, right? So I'm dealing with something for the esophagitis, I'm giving them some antibiotics. Now I'm having to supplement their vitamin A, D, E, and K, having to give them enzymes to make sure they can digest food appropriately. Like these kids can be on, 20 drugs, no problem, very easily just due to these complications of CF. So biliary cirrhosis can happen here. So this is where I actually use one drug. It's called ursodeoxycholic acid, or ursodiol, otherwise known as Actigol. Do you guys know where we get this one from? It's an animal source. Bear urine. Not bear urine. You're close though. It's from a bear. Huh? Well, it was basically from the bear, like rawr, bear. Yeah. But yeah. So the urso kind of gives that away, right? Ursa major, minor. Stargazing. Anyway, so so we basically get it from a bear gallbladder essentially. So we can actually have this, and it helps to emulsify fats and things like that to replace what the biliary tract would normally be spitting out those bile acids, right? We get that to supplement that so they can help to start break down fats and whatnot. But other manifestations you can have, obviously, if your biliary tract is blocked up, you have issues where bilirubin is starting to climb up, so you can see icterus, you can see ascites develop, all kinds of other problems associated with bile issues. And also chronic appendicitis can develop over time, so sometimes kids end up having to go to get that removed potentially as well. I mentioned already here, but they're going to have a lot of maldigestion, malabsorption. So, a kid who's not getting adequate enzyme supplementation, you can see issues with kind of these bulky, greasy kind of stools because the fats are not really being broken down and absorbed appropriately, right? So it's got to go somewhere. So you guys remember those Olestra chips or those Wow chips from back in the day? They basically prevented the fats from being absorbed. Everyone had like really horrible diarrhea. Same thing kind of happening here. What was that one drug that was over the counter for weight loss that did the same thing? Ally? That's what it was, right? So the same thing happened there. We're actually preventing breakdown of those fats, and then basically just kind of pooped them out. So they said, wear brown pants. Like, that was their countermeasure. I'm like, maybe a diaper or something. I don't know. But anywho, so lots of issues with absorption of food and nutrients for these kids. So we had to kind of supplement them for that and make sure they're getting enough. And then also you can have issues with progressive fibrosis of the pancreas that will be affecting other kind of endocrine functions, and so you can end up seeing CF-related diabetes develop. So now we're adding insulin onto their treatment as well. So lots of complications from CF. So I mentioned the hyperglycemia, so you kind of see this most often within that first decade, and so you can kind of treat them with certain, we haven't talked about the endocrine stuff yet, so we'll get to that and talk about the different meds, but a lot of these kids end up being on insulin in order to help kind of cover what the pancreas would have been doing otherwise, right? Again, it could be related to impaired insulin secretion, but they can also have some insulin resistance along with that as well. You don't really see them develop like DKA like you would normally see with a type 1 diabetic patient. So it's pretty rare, but it potentially could occur if they had really significant hyperglycemia or really severe deficit of insulin being released there. They will also have some issues with the genitourinary tract, so sexual development can be delayed because we mentioned there's a lot of secretory organs that are being affected as well. You end up having males will have either atresia or just absence of the vas deferens because of that. Just won't be able to develop normally. So you can have infertility develop because of that, so and some other issues as well. Females may have kind of a secondary amenorrhea that can happen. You can see, especially in the cervical canal, you can have kind of really tenacious secretions there, and so you end up seeing kind of a decreased fertility rate for those patients. So they're living for longer because we can treat some of these complications better nowadays, but again, their reproductive viability is not super great as compared to a patient without CF. And then we mentioned the sweat glands. Obviously, if they are not really able to sweat super well, you can end up having salt depletion. So again, we can reabsorb the sodium, but the chloride kind of gets stuck out on the skin. So this can lead, especially during warm weather, especially if you live in Florida, you can see things like issues with that, especially with gastroenteritis. You're already kind of depleted of fluids anyway. And so you get this hypochloremic alkalosis that occurs because all the chloride is stuck on the outside of the skin, and that's where you get that kind of frosting that occurs. Not like frosting like vanilla, but like chloride, basically kind of salt on the outside of the skin, and that's where you get you can lick a baby and tell if they have CF. Right? Don't lick babies though. So continuing on with our talks of CF, so again, general treatment. So basically, a lot of education up front. So once you kind of have the diagnosis, you can kind of help to prepare for a lot of the stuff that comes up. But you also would like to make sure you're getting a sputum sample for culture, and then also looking for antibiotic susceptibility. So we talked a lot about cultures previously in Farm 1. These are super important here. So especially when you're tracking these over time, you need to look at changes in susceptibility, right? So you may be fine using something like cefepime, which was what type of drug? Cephalosporin, generation 4, right? So 4th generation cephalosporin, and that may work for a while, right? And then so all of a sudden you redo your culture, and their Pseudomonas is now resistant to that. Now that drug's gone, right? So you can't really use that anymore. So you need to be tracking their susceptibilities, and also if you look at their prior history, you can make sure you don't give them antibiotics that they're already resistant to, right? So otherwise, you look kind of silly for doing that when they obviously have been resistant to it for years. So. Culture is very important. You also need to make sure they are hydrated well. Very frequently they come in very dehydrated, especially for these pulmonary exacerbations, whether it be related to gastroenteritis or whatever it happens to be. They usually come in very dehydrated, so they need lots of fluids to kind of help tank them back up, so to speak. IV therapy usually gets initiated pretty early, so they're coming in for an inpatient encounter for the most part. But so our goals here, obviously we'd like to preserve their lung function for as long as possible, mainly because we know this is the biggest cause for morbidity and mortality, so we want to keep them alive best we can. We want to prevent poor nutrition, so that way they can actually grow adequately and they don't have growth stunting and things like that. And then you're going to be assessing kind of their pulmonary history from visit to visit to make sure to see how they're deteriorating, see how they're getting better, all those things to see how your changes in therapy what influence they're having, and if they're getting worse or not, right? Some of these patients do get so severe on their pulmonary side that kind of what's the end therapy for them? Like we keep treating them, their lungs are just so crapped out. What do you do? Yeah, so some of them will go for transplant. So you'll find some cases for that where they actually do pretty well for the most part. I've seen just a few go for transplant. I haven't really seen them come back for follow-up because they generally improve pretty significantly after that. So I don't know what the necessary long-term effects of that are going to be, but I've had like 2 sisters who were teenagers, and one of them actually got transplanted first, and then eventually the other one did. But they would come into us like all the time for exacerbations, and finally, so it's great for them if they can do that. But then all of a sudden you're also adding on immunosuppressants on top of their other drug regimens, so it can get very complicated when you're treating with a lot of that. But anywho. So we'd like to make sure we can clear the secretions as best we can. So there's a lot of therapies we're going to do, not only drug therapy, but also a lot of physiotherapy. So a lot of them end up having chest physiotherapy with like vests that they'll put on that'll kind of like start to beat them down. You can do physical physiotherapy, whatever it happens to be, but that can help to clear secretions. I'd like to control their infections as best we can, and then we'll look at inhalational therapy and then also antibiotic therapy for their pulmonary stuff. So again, I mentioned the chest physiotherapy. A lot of times they're doing it with a vest. That kind of gives them a nice automated way they can still go and do other stuff while they're having their CPT being done. They recommend doing it anywhere between 1 to 4 times a day. But if you have a teenager, how compliant do you think they are with a lot of these types of therapies? They don't want to do it, right? They don't have to take a break out of their day to come and get their CPT being done, especially the more kind of ones with a lot of secretions. Like they may have to come very frequently or do it very frequently, so they are not going to be as compliant as you would like in a lot of cases. But looking back at the drugs, we used aerosolized antibiotics very frequently because we know that the lungs are obviously the biggest source for infections, so we like to treat as locally as possible. And what are the kind of the benefits of using inhaled antibiotics? So yeah, so they should be rapid acting because they're getting to the site very quickly. What else?
Oh, they stay local. They don't go systemic.
Yeah, so you don't see systemic side effects from these because they're all going to be local. Also, if you imagine the relative concentrations that you're achieving with inhaled antibiotics versus IV antibiotics, right? You get much higher concentrations because you want to penetrate as much of that kind of nasty, thick mucus as much as possible, and so inhaled antibiotics help with this. Okay, so we'll end up having kind of chronic therapy with some of these antibiotics, and you'll see some different ways we can do this, but Essentially, these help to reduce symptoms. They can reduce hospitalizations and also improve their pulmonary function, right? So this is all good things we can do for our patients. And then very frequently, you'll see them potentially being used as an adjunct for IV antibiotics. So if they come in for an exacerbation, you're treating them IV for whatever, then you can also add on aerosolized antibiotics. And then you'll also see them use it for long-term therapy at home. So it's very common that I'll see them being on like inhaled tobramycin or Toby nebulization. They'll be on that for 28 days, and then they'll be off of it for 28 days, and they'll be put back on for 28 days. That way you're not just having kind of just chronic suppression of the bugs and leading to stuff that's resistant to the tobramycin. Normally when you're doing inhaled antibiotics, you're getting such high concentrations that it's very difficult for the bacteria to really become resistant to it, because you're always kind of able to overcome that with concentration, right? You can't really do the same thing with IV because you cause lots of toxicities. So, but you go ahead and do that, 28 days on and off, so that way you kind of avoid kind of that selection pressure and get more resistant bugs for the most part. But aminoglycosides are really good for this, right? So it's not going to get your gram-positive infections, but it will cover that Pseudomonas that you're really worried about, and other gram-negative. So tobramycin is the most common one. That one actually comes with the Toby nebulizations. And then some other cases we may actually use gentamicin, amikacin, other aminoglycosides. We'll put that into a nebulizer cup with some saline, and they can inhale that on their own, right? Other things you may see, cholestyramine, which is a colistin, that is very similar to like your polymyxin type antibiotics, which are very, very lots of side effects, lots of neurotoxicity and nephrotoxicity when given IV, but given by the inhaled route, you don't really run into many problems with that. And then sometimes ceftazidime or Fortaz gets used. You guys remember what type of antibiotic that is? It's cephalosporin. What generation? I know you guys can recognize the cephalosporin, but I'm usually trying to get at what generation it is. 3, yeah, so it's a 3rd generation cephalosporin. This is one of those ones that have activity against Pseudomonas. I told you guys never to use it for Pseudomonas because resistance is real bad. But CF patients is kind of the one place where you might see it being used occasionally, either because it's being used IV because that's the only thing their Pseudomonas is not resistant against, or because we can use it inhaled and kind of overcome that resistance pretty easily. So occasionally you'll see ceftaz being used by the inhaled route. But usually tobramycin is the most common one that'll be used out there. There's also a new drug here called Pulmozyme. The generic is Dornase alpha, and essentially this is a recombinant product. It's a enzyme that we're giving. Basically, you inhale it once every day. This is extremely expensive. Very, very costly to give this because it is a protein-based product. But essentially what it does is it actually starts to cleave the DNA in the nucleus and these kind of generating neutrophils you find in these secretions. So basically it's able to kind of help loosen up a lot of the mucus that's being kind of gelled and kind of causing obstructions within the lungs itself, okay?
So this is not an antibiotic. This is actually just to increase this.
Yeah, this is called a mucolytic, which means it's going to try to lyse up that mucus, allow better penetration for secretions of water and things like that in order to clear that mucus better, okay? A couple different meds we can do for this, but Dornase alpha or Pulmozyme is the most common one you'll see used being used in CF, okay? Expensive product, as I mentioned, but it helps to kind of loosen up secretions. They can process it better and help to expel it and hopefully aerate a little bit better. I'll talk about in a second. I'll talk about the order in which you give these therapies because that's also important as well, right? To make sure you're maximizing the benefits of your drugs. Sometimes you might see this in patients who have really, like an ICU patient who's got like a ventilator cord pneumonia, who has got really nasty bad secretions. Sometimes docs will use it for that, but there's not a lot of evidence behind that, right? So it's just kind of a high cost thing they're doing to hopefully try to clear secretions. There's other drugs we can try for that as well. Another thing that can act as a mucolytic is by giving hypertonic saline. Again, giving high concentrations of saline can help kind of draw in water into that area and kind of help loosen up the secretions. You guys remember what percentage normal saline is? 0.9%, right? You guys remember how many milliequivalents of sodium that is per liter? That's good to know if you're ever treating like hyponatremia or something like that. It's 154 milliequivalents per liter, right? So that kind of makes sense because if you're looking at normal saline, it's supposed to be similar to blood, right? Tonicity-wise, osmotically. So it's 154 milliequivalents of sodium, 154 of chloride. It basically equals 308. And what's the normal osmolarity of blood? Right around 300, right? So that's why it's normal saline. Anywho, we're using hypertonic saline, so now we're just increasing that percentage, roughly 7 times, and that helps to draw water in and break up those secretions. So you use hypertonic saline. You may see 3%, but 7% is the most common to do for these kids, right? This is kind of rheologic property, which basically means it lets things flow better. So it helps to kind of let the mucus kind of lubricates it and allows it to be expelled by the patient a little bit easier. And it helps to hydrate the airway surface. So all of these are good things, kind of help improve mucociliary clearance. Sometimes you'll see this used in conjunction with Dornase alpha. Sometimes it'll be used instead of, right? So it just depends on the patient, how bad their secretions are. For these pulmonary exacerbations, they need to be really treated pretty aggressively, and you need to make sure that they are getting adequate length of therapy, right? So these secretions are hard to penetrate, and so they need at least 2 or more weeks of therapy in order to help really clear, really they're never clearing the infection, they're really just kind of knocking it back down enough, making kind of latent, so that way the patient can kind of improve their pulmonary function and go home, right? It's really the big thing. But antibiotic therapy is going to be the big thing we're doing here, up to kind of control that progression of the lung infection. And so antibiotic selection is going to be based on past sensitivities and what they're currently cultured out, right? Because you need to put them on something, they present to the ER, they're having a pulmonary exacerbation, their SATs are in the low 80s, like you got to do something for them. So you're going to put on empiric antibiotics based on previous cultures, and then when the new cultures come back, then you can make new decisions about what you need to treat with, right? So, obviously lots of different things you're going to be seeing when they're having these exacerbations. Obviously, you're going to have some radiologic findings, but just their symptomatology can be pretty obvious. Lots of cough and sputum production, but you can have weight loss, poor appetite, all kinds of other things that can be seen here as well. Our treatment, though, sometimes you can get away with oral antibiotics for more kind of minor infections. If you're trying to prevent them from getting admitted, you can try using this for using oral antibiotics. So if they have grown, predominantly Staph aureus previously, we can use anti-staphylococcal penicillins, right? So you guys remember, that's like our dicloxacillin. You guys remember any other ones? Say oxacillin, nafcillin, like those are anti-staphylococcal ones. Obviously, if it's MRSA, that's not going to work, right? So you're going to have to potentially step up therapy. Something like maybe clindamycin might be effective against that. So you can kind of go back and pull all the dusty cobwebs off that antibiotic lecture and kind of remember your coverages. H-flu, you can use things like amoxicillin plus clavulanic acid. Do you guys remember what the brand name for that is? Augmentin. What's the clavulanic acid doing? It's a beta-lactamase inhibitor, so this is better for more resistant H-flu. Potentially, if they've gotten vaccinated against this may not be as big of an issue, but there still can pop up occasionally for those that have not received vaccines. And then Pseudomonas is oftentimes going to be the big thing you're trying to cover for. So especially if you don't have any previous cultures and you're treating empirically, you need to have coverage for Pseudomonas. And so orally, you may see ciprofloxacin or other fluoroquinolones being used, or you may go with just the inhaled route. So something like tobramycin or colistin via the nebulizer might be good enough in those situations, right? So this is for more minor exacerbations where you're trying to prevent them from getting admitted. Okay, very frequently this might not be the case. You might do some subset of patients, but for the more severe ones, more progressive ones, they're probably going to have to come in on the inpatient side. So this is where we use our IV antibiotics. You need to treat for the Pseudomonas, right? Because we know these patients are going to be colonized with it, and so we need to treat with a minimum of 2 antibiotics for that, right? So you guys remember we always double cover for Pseudomonas, no matter what type of pneumonia you're dealing with, because you worry about resistance. Most frequently, they get put on an aminoglycoside plus an anti-pseudomonal beta-lactam. You guys remember any options for that? Piperacillin, tazobactam, right, which is Zosin's a big one. You guys think of any other ones? That's the primary one you're going to be dealing with. And again, with aminoglycoside, gentamicin, amikacin, tobramycin, all those will work equally effectively. You could also potentially use like a cephalosporin, so anti-pseudomonal cephalosporin, so something like cefepime might be a good option there as well. So Zosyn, cefepime, probably going to be your go-to kind of beta-lactams. What other, just beta-lactams in general, not penicillins, what else could you use potentially? You remember the carbapenems? Imipenem, which comes with that cilistatin, and then the other kind of go-to. Meropenem is the other big one, right? So we use a lot of meropenem for these kids because of resistant pseudomonal infections. So you can start off with like a Zosyn or cefepime, but a lot of times they end up having to get transitioned over to the carbapenems, usually meropenem, what I see used most often. So, right, so those are going to be kind of your best options there. As I mentioned, you may need a 3rd antibiotic for adequate coverage if you're worried about Staph aureus, in which case what do I use? IV therapy for Staph aureus. Vancomycin is going to be one of your big go-tos. Sometimes clindamycin might be used occasionally, but vanc is probably the most common one. So you'll see these kids come in, they'll be put on, tobramycin, cefepime, and vancomycin. That's usually a pretty common cocktail. Or they may need coverage for something like Burkholderia cepacia if you know they've been growing it previously, right? I mentioned that's a bug you see normally with more kind of progressive disease, usually later on in their presentation. And actually the treatment for that is going to be Bactrim. You guys remember what the components of Bactrim are? Yeah, so trimethoprim and sulfamethoxazole, the two components there, right? So Bactrim is actually going to be the drug of choice for treating Burkholderia cepacia. That's only really you have a suspicion there that's what's causing their infection, or if they've grown it previously, you would kind of think that more. So very frequently we're going to use just once daily antibiotics. These kids normally don't have any problems with their kidney function, but as I mentioned, what's their fluid status when they normally come in for these exacerbations? They're dry. Yeah, usually they're pretty dehydrated. So they may have kind of an acute hit on their kidney function, it appears, but usually it's just pre-renal. So once you tank them up with fluids and you repeated their labs, their kidney function will look great, right? So we have usually no problems with that. So they can get really big doses of antibiotics, the aminoglycosides, because going back to that one, is that a time-dependent or concentration-dependent killer? Aminoglycosides.
Concentration.
They're concentration dependent, right? Because I can give it once a day, right? So the concentration dependent. So I want the concentration as high as possible because I need to penetrate those nasty secretions in the lungs, right? So I need to give really big doses in order to achieve that. So here, we'll give big doses to say like, tobramycin, like 10 mg per kilo, one time a day, get really high concentration in the lungs to try to eradicate that infection. Okay, their kidneys can handle it. They clear it very, very effectively, and in fact, they actually can clear it because they're. We'll talk about some kinetic changes you see with these patients, but in general, they end up clearing this a lot faster than even like normal adult patients, right? So usually we'll end up kind of looking for those peak levels, say 20 to 30 mics per ml, and then we look for trough levels that are undetectable. You don't have to memorize the dosing or the levels we're looking for. Just realize that we're using once daily dosing in order to achieve that concentration-dependent killing that the aminoglycosides are good for. Okay. Amikacin you can use as an alternative as well. It just depends on what your formulary items are and things like that. So I mentioned we have a pretty big change in their pharmacokinetics. A lot of that is based on kind of their secretions. A lot of it can be based on their nutrition. Like usually CF kids, are they usually kind of overweight or more thin? Yeah, usually they're pretty thin because I mentioned the malnutrition issue. I mentioned, just the fact that they're having kind of these, chronic pulmonary exacerbations. Like, they in general are pretty thin for the most part. So they have more lean body mass, a lot of adipose tissue, and then the lungs themselves kind of serve as a large reservoir for drugs and other things, especially when they have an exacerbation, they're having lots and lots of secretions in there. It kind of serves as a big reservoir for things. So you can see increased in their volume of distribution, especially for hydrophilic meds, right? So we mentioned the aminoglycosides already, some of those. And then they actually end up having that enhanced body clearance, like I mentioned, so they can clear those drugs very, very quickly. And so sometimes we actually run into the problem where, most patients you worry about antibiotic dosing and the fact they can't clear it fast enough. Sometimes we're having to give them even higher doses just to make sure they're getting good concentrations because they clear it so quickly. So especially with like vancomycin, if we're dosing them for that, sometimes we're giving them huge doses of vancomycin just to keep the trough up because you guys remember vancomycin, time or concentration dependent. Time dependent, right? So we want to keep that trough up above there. And you guys remember we talked about different trough levels for vancomycin. Would you shoot for kind of a normal trough, or do you think you need a higher trough for these patients? Probably higher, right? Because anytime you're trying to penetrate the lungs with vancomycin, it's already going to have a hard time. These patients are even that much worse. So you need to usually shoot for high troughs there. And so we have to give them massive amounts. We're having to give it pretty frequently in order to achieve that. So this gets to be very difficult to get good levels of those time-dependent killers. So as a result, you're going to see higher antibiotic doses in general for CF kids than you would for other ones. So other things we can see being used, occasionally you might use some anti-inflammatory agents. Things like corticosteroids can be used for kind of acute exacerbations. So what are some options for IV corticosteroids I might use? Methylprednisolone is a very good one, right? So you might see that being used IV. Decadron or dexamethasone, that's a good one. What about orally? Could I use prednisone, dexamethasone? I could use that as well. So those are probably the most common ones you'll see being used as far as corticosteroids go. Ibuprofen obviously can act as an anti-inflammatory, as an NSAID, and then we'll actually, this is kind of an odd thing that you'll see, if you ever have a patient who is on azithromycin Monday, Wednesday, Friday, chronically, that's usually a CF patient. They're not using it to treat the infection, they're actually using it as an anti-inflammatory to try to prevent some of those long-term pulmonary changes that occur. Okay, it's kind of an odd dosing. You may be like, why are you on this? Monday, Wednesday, Friday doesn't make any sense, but that's why it's for CF kids to try to prevent that inflammation. I can't give you a real good mechanism, but it works apparently. So, and then, if you consider if they're not getting better on antibiotic therapy, you have to start considering things like mycobacteria. Like, okay, do they have like TB, or is there something else kind of going on here that's growing? Is there a fungus growing, right? So you can have fungal balls that can end up developing in some of these patients. They have, especially immunocompromisation on top of that. And other kind of atypical bugs that may be growing that don't show up on a normal bacterial culture. So, moving on to looking at the nutrition, obviously they're going to have a higher metabolic rate than others because they have a higher kind of baseline as far as like working to breathe, right? So they're having to work harder, they're burning out more calories, and so usually you're going to have them have a very high fat, high protein diet. A high protein, high calorie diet with normal amounts of fat, right? Because we mentioned the fats don't get really emulsified or broken down very easily. They typically need a pretty high protein diet for the most part. Okay. So what we can do for them is actually give them pancreatic enzyme replacements, though. This is going to help them to kind of break down all those different products and can help them to absorb that a little bit better. So we'll give them, basically they'll have, they eat a lot of snacks as well in order to make sure they get their calorie counts. So you'll oftentimes see orders for, pancreatic enzymes with meals, and then they'll have a separate order for, snacks as needed. So basically, as they'll eat and get snacks, and a lot of times they're not really hungry, so that's another thing that kind of prevents them from really gaining a good amount of weight. But you'll have them have kind of separate orders for that sort of thing. Basically, we give them lipase, protease, and amylase in a pill form. And I said most of the time we don't give enzymes orally, but here this makes sense because it's meant to handle the stomach acids. It's kind of protected until it can get past there and it'll then kind of release itself and be able to break down those foods. A couple of different brand names you may run into. So if you ever see a Pancreas, Creon, Zenpep, those are probably the most common ones you run into. And you always dose it based off of the lipase content of there, right? So you'll have a Creon will be like 25, 30, whatever number, and that's basically telling you how many units of activity of those different enzymes that the product has, right? So basing usually off the lipase content in order to help break down those fats so they can absorb that even better. So you'll see that usually the doses will be a little bit bigger with their bigger meals in order to help make sure they can do that. How would you know if the patient wasn't getting enough enzymes? So you're treating a patient like they're eating, but they're like, oh, I'm experiencing this. That would give you a sign that they're not really getting enough enzymes. Yeah, they're having a really nasty, kind of fatty, foul-smelling stools. That's usually a good sign that they're not getting enough enzymes to break down their food, right? So that would be indicate an increase in dosage you want to give for those patients. Okay. So you can't really drive up the dose too high. You can actually end up seeing this problem, the fibrosing colonopathy and colonic strictures that can occur. So as if they didn't have enough problems. But if you imagine you're giving protease, which just doesn't work only on your food proteins, it works on all proteins, right? So it can help damage the colon long term with really high doses. So we run into issues with that as well for some of our patients. You can also give things like proton pump inhibitors or H2 antagonists to kind of help increase the pH and allow for the fat to be absorbed a little bit easier. So that's kind of another method we can try there for those patients. You also want to make sure you're supplementing their fat-soluble vitamins. So this is where we have things like our A, D, and K that need to be given in higher amounts. So you'll have different things like Aquadex, you have Source CF, so lots of different brand names for that. But just realize that's what we're supplementing when we do that, because normally they're going to have kind of baseline low concentrations of those 4 vitamins. We mentioned the ursodeoxycholic acid, which does not come from bear urine, but from bear bile acid. And so basically it helps to decrease that the cholesterol content of the bile, and basically helps to reduce that secretion of cholesterol from the liver. So basically by giving enough bile acids kind of artificial bile acids orally, it kind of helps to prevent the bile duct from thinking it needs to release as much. So it kind of helps to relieve some of that stress on that. But obviously some of these patients may end up with end-stage liver disease based on this kind of chronic blockage of enzymes and things like that. So you can end up needing transplant in some longer-term, more progressive cases. They are frequently going to have GERD issues, so we talked about that and treating them. We'll talk a little bit more about treating GI disorders in kids probably the next time that we meet, but sometimes you will not want to use certain drugs to help kind of these patients just due to their pathophysiology. So for instance, like, if they're having aspirations of stomach contents, that can lead to a pulmonary exacerbation. So you really want to deal with that. You want to make sure you're dealing with that excess acid and deal with GERD reflexes, deal with GERD symptoms, because it can be more problematic for these patients than it would for other ones that have normal lung function. But you don't want to give cholinergic agonist, right? Because we mentioned the muscarinic receptor, and you activate that, that helps to kind of produce that nice gastric barrier, kind of help with those. You don't want to do that because that can actually increase mucus production elsewhere in addition. So that'll happen in the lungs and cause an exacerbation. Don't do that. But you can use like proton pump inhibitors. Usually you want to use a little bit kind of more heavy duty acid blockers, and so PPIs are good for that. One of the new agents that we have for treating CF is this combination drug. It's called Lumacaftor and Ivacaftor, and the product is Orkambi. And so we're starting to see this being used in several of our CF patients. This is probably in the past year or two that I've started to see this being used more frequently. And so it's for patients who have a homozygous delta F508 deletion. Okay, so you'd have to do the genetic testing, and most of the patients already have that done to know what type of mutation they have. Okay, basically the Lumacaftor improves that conformational stability of the protein itself, right? So it's able to basically increase that processing and trafficking of getting the mature protein, of that chloride channel, up into the cell surface. Okay, so it helps the cells to actually produce those proteins and get them out to the cell surface a little bit better. And then Ivacaftor is a CFTR potentiator that increases the activity of the protein itself, right? So Lumacaftor gets the transporters up into the cell surface, where the Ivacaftor makes it work a little bit better. And then more chloride flowing kind of establishes more of a normal kind of function than the patient had previously. You do want to take it with fatty foods, helps to increase the absorption with this, and we already know they have problems with fat absorption anyway. For the most part, it is pretty well tolerated, but you do see some issues like menstrual irregularities, so you see it a little bit more commonly in patients who are taking oral contraceptives for whatever reason. And maybe some rare hepatotoxicity, but for the most part, it's tolerated very well. I can't say specifically how effective it is. I don't follow those patients in particular, so but I see a lot of them on it nowadays, and it appears to help to some degree. Yes.
Is this for just gastrointestinal problems in general?
No, this is for all of the CFTR transporters everywhere, right? So potentially you could see improved lung function, you could see improved GI function, so hopefully it's helping kind of everywhere. So you can kind of imagine looking at just some of the materials coming from the drug manufacturer itself to kind of give you an idea of what the function kind of looks like. Notice how here you're looking at in vitro activity. You can actually see percentage of normal CFTR activity. It looks to be higher than with no drug whatsoever. Again, this is all from the drug manufacturer, so take that with a grain of salt. But looking at the actual mechanism here, this kind of makes it a little bit more clear what's happening. Normal proteins for a patient without CF, these proteins are getting out to the cell surface to allow the chloride to flow, whereas here, these are defective, right? So those are most CF patients. With Orkambi, you can at least get some activity back. It's not going to be 100% of what your normal patients would be, but it's at least something, right? So something may be better than nothing. Okay, so that's pretty much it for management of CF. One of the things I don't know why I didn't have a slide on that, but one of the things that's really important is the way that you organize their pulmonary treatments, right? So when you're giving them their stuff via nebulizer. So if you imagine, how would you go about treating these patients? Because you want to give antibiotics. You want to give their mucolytics to make sure you're breaking up the mucus and getting rid of that. And you also have the CPT that you're doing as well in order to help clear the stuff. So if you had to imagine, which therapy would you want to do first? Okay, so mucolytics. Why would you want to do mucolytics first? Yep, so it can loosen everything up. It can help to hydrate it and try to help break it down a little bit. And then what would you do next? the CPT, right? So then you do the chest physiotherapy because that's going to help to kind of loosen it up and help the patient to get rid of it, to expel it, right? So they're hacking up all this nasty mucus. And then what do I do last? Antibiotics, right? Because now I'm able to kind of better penetrate the lung tissue a little bit better. I can get a little bit deeper for those antibiotics, and they can have better activity, okay? So if I did antibiotics first, you know, all they're hitting is that really nasty thick secretions. They may not really be able to penetrate that well. So the ordering of those therapies is really important. So I might do something like hypertonic saline, followed by Dornase, followed by the CPT, followed by tobramycin inhaled, okay? So ordering of that is important. Does that kind of jive with what you did if you ever dealt with CF patients? Perfect. All right.
We kind of did the mucolytic at the same time as the CPT.
Sure. Yeah. So yeah, timing wise, that probably makes it a little bit easier to kind of knock two birds out with one stone. So if the RT says it's okay, then I'll use that as my backup. So okay. So any other questions? I'm probably going to cut it here for today, and then we'll go and do the rest of this Tuesday, and then the review on Thursday. Yes.
If the muco did and it's definitely no longer used for this year?
Yeah, so that's a very good point. So before we had Dornase, we used to use N-acetylcysteine, which is usually used as an antidote for acetaminophen toxicity, but it also can be inhaled as a mucolytic. And actually, my first job as an intern in a hospital pharmacy, I got to be as a low man on the totem pole, so I got to take the N-acetylcysteine. You guys know what it smells like? Rotten eggs. There's a high sulfur content, so it smells like rotten eggs. And so I was tasked with divvying out big vials of it into small containers for inhaled use later on. That can also be used as a mucolytic. I don't see it used quite as much anymore, since at least on the Peds side, since we have the Dornase. So certainly you might your mileage might vary depending on where you're working at, but N-acetylcysteine can be used as a mucolytic as well.
Can you use over-the-counter Mucinex or anything?
No, the guaifenesin doesn't really do as much activity because you know it has to. It's not really as strong. Yeah, you really need, like, these are some gross secretions you really need to get rid of. So yeah. Any other questions? Okay, I will see you guys next time.